Hello, my name is Jeff Sandman, CEO of Hyde Communications. Thanks for joining us for this video podcast. Today we're talking about comparative effectiveness research with my colleague Dr. Mike Miller, also president of HealthPol.com. Mike, thanks for joining.
Thank you, Jeff.
There is apparently real consensus, or apparent consensus, on the Hill amongst legislators, regulators, policymakers, and I think constituents on all sides that this issue is now on the agenda. That's something important to do. What's going to happen here?
Well, Jeff, as you know, there's already $1.1 billion that's been allocated for comparative effectiveness research in the stimulus bill, and it's really a down payment on health reform as a way to provide information about really what works better and what works maybe less better in healthcare, both system structure as well as specific therapies. And that will be used as a way to feed into the debate about how our health system should be transformed going forward.
Right. You know, Mike, it seems, this issue has been around for a while, and I think we're reaching new peaks. There is a tension here on one hand between cost containment and the real dramatic squeeze being felt all around because of the economy, and two, how companies can show value for the new medical therapies and devices. How has that changed, and how will folks show that value?
Well, I think it's what you've hit upon is really the tension as well as the balance between quality improvement through comparative effectiveness research as well as cost containment through comparative effectiveness research. And that's going to be, it's really the two sides of the coin in CER. And depending on what hat you wear, one is more important than the other. For clinicians and patients, it's really the quality improvement. How can we reduce the uncertainty about whether a therapy will work? For a health system administrator, how can we structure our delivery system to reduce the uncertainty that we'll have errors or that we'll spend more than we need to on certain kinds of care or for certain disease areas, whether it's congestive heart failure, diabetes, cancer. So that's really the challenge, and that really flips over into cost containment because it's been shown that quality improvement can really reduce costs.
Mike, we look overseas at the example often touted, the NICE system in the UK, and a lot of it is rather negative news, used as CER being used as a means of saying, no, we're not going to pay for some of these therapies and devices. So what are some of the implications both for life science companies and patients, and who's going to win and who's going to lose as cost-effective research goes forward?
Well, I think the difference now and going forward versus what NICE has been able to do or tried to do is that we're going to have a lot more information about the actual value of the healthcare products and services and delivery systems, and that's going to be used to increase transparency and accountability, which is really two catchwords that I think should be applied both to CER and how it's going to be used in healthcare transformation. And I think the winners are going to be people who can actually come through with more transparency, and the information that becomes more transparent will be used to hold people accountable for the value they're providing, whether it's a product, whether it's a service, whether it's a delivery system structure. So that applies to life sciences companies as well as clinicians, hospitals, and health plan administrators. It's going to apply to insurance companies too.
The leadership in the Senate has promised a health reform bill by June. And curious where we think this is going to go and how quickly effectiveness reform and research gets included as part of the debate.
This kind of research has been going on for a long time. The stimulus money is going to put a big boost to it, but original research takes a long time. It takes years to do the research and get the results and analyze it. There's also secondary research of taking pre-existing knowledge and reanalyzing it that can be done in a CER sense. That will be available quicker, but still takes years to do that. So I think it's, again, a down payment that's going to influence and inform the transformation of healthcare in the United States and around the world, but it's going to be a long process, and I think a productive one for those who can be transparent and accept this new sort of accountability and value environment we're moving into.
On all sides.
On all sides.
So this conversation is clearly going to continue, this part of the debate. Thanks so much for watching. We'll be back with other issues in healthcare reform in the coming months. Thanks and goodbye.
Thank you.